Hello, good morning, and sorry for the delay, just getting up the slides in place. I would like to thank the All India Ophthalmology Society and the College of Ophthalmologists for giving me this opportunity to speak on surgical management tips on peripheral ulcerative keratitis. As you know, peripheral ulcerative keratitis is a destructive inflammatory disease of the juxtalingual corneal stroma that is associated with epithelial defects, presence of inflammatory cells in the stroma, and progressive stromal melting. It could be associated with various ocular as well as systemic infectious and non-infectious diseases.
Sir,
The
please
basic
share full screen mode, sir.
Sorry to interrupt you, sir, but your the presentation is not in a full screen. We can see different slides at the same time. Could you please make your screen full?
Yes, sir. Yes, sir. Okay, thank you.
Yes, sir. Now the screen is completely visible.
Okay, so basically the pathophysiology is there is an imbalance between the levels of specific matrix metaproteinases and tissue inhibitors in peripheral keratitis. And this is the reason for the rapid keratolysis, which is a hallmark feature of the condition. And corneal fibroblasts, the keratocytes, play a crucial role in it. So when we see there is involvement of the adjacent structures like conjunctiva, epistellar and scleral information, and with timely diagnosis, detection of the underlying systemic inflammatory disease and proper treatment, we can treat PUK and its involved sequelae. Usually the patient will present with redness, pain, watering and photophobia, and pain is a prominent feature and it may be severe. And any excruciating pain out of proportion to the severity of ulcer is often a characteristic feature of Murren's ulcer. The decreased vision can be a late presentation because sometimes the patient may have normal or subnormal vision, but long-standing cases, the reduced vision may be due to induced astigmatism, corneal opacities, or treatment side effects like cataracts and glaucoma. And also patient can present acutely if there is corneal perforations due to the thinning of the cornea. There can be many systemic manifestations of the PUK, and there can be also occult systemic diseases. And a thorough systemic history is very important to find out the cause of the disease. Because it's associated with a large number of diseases, it is very important to diagnose etiology in peripheral ulcerative keratitis. And most often you can find an etiological cause. Like I said, these are the various diseases. So there can be inflammatory diseases, infections, ocular surface instabilities, and limbal stem cell deficiencies. There's a crescentic ulceration with an epithelial defect and thinning of the stromal infiltrate at the limbus, and it begins as a crescent-shaped white infiltrate. So you can have an overhanging edge with stromal loss and thinning and adjacent stromal infiltrates. So this is a patient who presented with thinning of the cornea and melting with an iris plug at the perforation site. So Murren's ulcer is an ulcer of exclusion, diagnosis of exclusion made in case of PUK without any systemic association or without scleritis. So how do you differentiate PUK with the Murren's ulcer? Pain is not severe as in Murren's ulcer. The extension into sclera may occur in PUK, and there is no separation between the ulcerative process and the limbus. It is always important to exclude any infective cause before you start treatment with steroids in PUK, because if you start with steroids and without any microbial treatment, then you can aggravate the situation. How do you know this is due to infective cause? It is, so usually you have a trauma history with vegetarian matter, history of contact use, or past history of viral keratitis. The main goals are to ensure quick healing of the ulcer with minimum sequelae and to avoid recurrences. So there should be a balance between the medical therapy, local and systemic surgical intervention, and usually a multidisciplinary approach is usually needed for treatment of these patients. If we come into surgical management, earlier we used to use large grafts because even for smaller decentered or extra central grafts, because we had no other options. But these were prone to increase the chance of vascularization, peripheral anterior synecdoche, and anterior chamber and graft failure. So what are the treatment options? We usually do a conjunctival resection because we need to remove the limbal source, because it is thought that the vasculature causes the interactions and brings the infective foci, the inflammatory foci, and it also may be of a diagnostic help. We can use tissue adhesives with glue, patch grafts, which we use now, superior lamellar keratectomies for any opacities in the anterior cornea, and conjunctival flaps. But conjunctival flaps should be used judicially because they can incite, bring in the causing agent and cause more inflammation. We have a match and patch technique where we match the patch, the host, which is the defect to the host, and then we graft the needed area. If you can see, this is the cornea and we can match the area. So this is the graft that is there. We can match the area and patch to that graft. So if you can go into the video. So this is a patient who had an extensive peripheral artery keratitis. It is always important to find the exact margins before you go in for the treatment and grafting. What I usually do is I usually get about 0.5 to 0.75 excess to the edges, because very important that when you do the grafting, you should have a healthy donor site for the sutures to take adequate biting. Then with a marked trephine, you can get the margins of the thinned out area. And it's very important not to give in a lot of pressure, because this can perforate the cornea. And then with minute manipulation, you can get the edge of the cornea and make sure that you have adequate, you have separated all the synecdoche using viscoelastics on and an iris repositor, so that you don't inadvertently catch the iris. After the cornea has been excised, it is very important to separate all the synecdoche which is attached. You can use either BSS or methacellose, and it is very important you remove all these additions, because if the additions are not removed, these can cause further problems later on. Again, I take about 0.5 to 0.75 excess to the margins of the donor area, because that will help us to give in tighter sutures, avoiding gross astigmatisms. You follow the basic suturing techniques for the grafting, making sure that you have adequate bites in both the donor and the recipient. And at the end of the surgery, make sure that the cornea, the eye is airtight with no leaks. So this is the patient who had a peripheral melt, a C-shaped, banana-shaped melt. And it is important because most of them have the iris has been out for a long time. So make sure that the additions are removed before you start the suturing. It is always important to remove all the additions between the cornea and the iris. So because this was a relatively smaller patch, I thought I can get the donor cornea by putting it over the melt. So what I did here was I took the cornea, and with corneal markers, you can get the exact measurements that are needed, and always make sure that you get it slightly larger than the actual defect. Because if you have a same size graft or a smaller one, later on when you try to suture it, you will have quite a large astigmatism. And always, like I said before, make sure that the edges that you have to graft are all have a relative thickness, so that you won't have any cheese wiring. And after the grafting, you can make sure I usually instill an air bubble into the antechamber to know that the grafting is okay and there are no AC leaks. So what are the post-op considerations? You have to continue treating the underlying diseases, management of the grafts with reducing inflammation and to prevent graft rejection. It is very important to manage the ocular surface with lubricants because they usually have quite severe dry eye conditions also, and also they can have Delan formation and visually rehabilitation and time suture. So in conclusion of this first talk, so the potential PUK is a potentially blinding disease and it's considered more sort of therapy, but with proper management and multi-disciplinary approach, you can manage them safely. Surgical therapy, although technically challenging, can give better prognosis in all stages of the disease. This is a small presentation on what to do when you have descemal rupture while you are preparing for a DSEC. So basically, this is the evaluation of DSEC. We initially had penetrating keratoplasty, then it went on to deep lamellar endokeratoplasty, which was quite daunting task to do. Then we had D6 and D6, and then DMEX or descemal membrane endothelial keratoplasty. What are the indications we have for bullous keratopathy, Fuchs dystrophy, failed PKs or D6, eye syndrome, toxic anti-segment syndromes, and congenital hazy endothelial dystrophy. So why do we usually do endothelial grafts in case of full penetrating keratoplasty? The visual rehabilitation is rapid. There are no suture related problems, less astigmatism, the graft, the eye is stable, no ocular surface problems. We have fewer rejections and small incision with less risk of suprachoroidal hemorrhages. So if you can see, usually what I do is I have a marked refine of about 350 micrometers, which I go in, and then with the crescent knife, I get the initial incision to get the cleavage plane. And with the blunt dissector, I go in with the dissector. If you have an anti-segment OCD, this is very convenient, so you know the exact depth, but unfortunately, when you don't have it, you have to rely on this, and you can see it perforates here. So without discarding this eye, what you can do is you can suture the initial site that you made the incision, and always make sure that the antechamber, the pressure is not tight, so it should be slightly less tightened, and then from another side you can go in, and I have put in an air bubble so that I know exactly at which plane that I'm going now, and always make sure that you dissect the perforated part where the suture is at the last.
Sorry to interrupt you, sir, but your time is finished. So, and
Right.
we are running out of time. Could you please
Okay,
sum it up? Yeah.
Yes. Okay, so this is the end. Okay, so this is a post-op patient. Right. Thank you.